So I'd just like to welcome everybody as well. As Jerry said, my name is Todd Anterior. I'm with orthopedic surgeons with Coordinated Health. I do general orthopedics, but my subspecialty interest is in sports medicine. Sports medicine encompasses a pretty wide range of injuries. Most common things we see are knee and shoulder injuries, but we do a little bit of everything. As he said, my training was in sports medicine. I did a fellowship in sports medicine in Baltimore. And I've been here in the Lehigh Valley now for about the last 5 years or so. So, just as an outline about what I'm going to talk about here tonight, again, the focus is youth sports injuries. First of all, I'm just going to make a few comments in general about children in sports. Then I'm going to concentrate on some specific injuries. We're going to talk about a few acute injuries, but also a number of overuse injuries, and we'll differentiate between those. And then the last thing I'm going to touch on is a little bit about prevention of sports injuries, as well as treatment, and then Frank Louis is going to take over and talk a bit more about prevention. So every day, millions of young people participate in sports activities. Taking a few precautions can keep everybody safe so that they can enjoy the benefits of sports participation. Unfortunately, every year, thousands of children are injured during sports participation and ultimately have to sit out. Participation in both both organized and informal athletic activities is increasing in the pediatric population across the board. Children are getting into competitive sports at younger and younger ages. Participation by females is increasing very rapidly. And unfortunately, children can be more susceptible to sports-related injuries based on their immature skeleton. Over 800,000 children ages 14 and under are treated in ERs every year for sports-related injuries. Most of these injuries result from falls, being hit by an object, but oftentimes they're a result of overuse type injuries. More than half of all organized sports result in injuries that were actually preventable. As I said, 30 to 50% of these injuries we see we feel are related to overuse. These are most common in sports that require repetitive motion. Repetitive motion leads to micro-trauma, and micro-trauma is the source of an overuse injury. Sports such as gymnastics, dancing, pitching, and running are some of the common culprits that we see. Despite these risks, when it comes to children in sports, the chance of injury can be minimized significantly. To this point, what we have to keep in mind is that children are not small adults. Their young bodies have bones, muscles, and tendons that are still growing, and unfortunately this does make them a little more vulnerable to injury. At the ends of bones when we're growing, when we're children, we have growth plates. This is the area where we have developing cartilage, and this is the area where the bone grows from. In young children, the growth plates are actually weaker than the nearby ligaments and tendons, and as a result, what might result in a bruise or a sprain in an adult can actually result in a bony injury in a child. On the left here, you see the x-ray of a pediatric knee. You can see the growth plate, which is here at the end of the thigh bone and here in the top of the shin bone, and this is an adult knee, where you don't see the growth plate. The growth plate is fused. Ligaments are structures that connect bone to bone. And as I had said, in an adult, when you stretch or strain, you tend to injure that ligament because that's the weak part. In a child, it's actually this growth plate that's the weak part. So unfortunately, a child is much more prone to having a bony injury than a ligament injury, which we see more commonly in adults. Further marking the difference between adults and children is the fact that children mature at very different ages. You can have children that are the same chronological age, but they're developmentally completely different. And generally, these kids are going to be competing together, and that can present problems from time to time. Now I'd like to talk about some specific injuries. Again, as we said, we can kind of group injuries into two major categories. Acute injuries are the injuries that result from a sudden trauma. These are the sprains, strains, bruises, and fractures. One of these injuries, these are the injuries you know about. You know something happened. The other type of injury is an overuse injury. It's generally not a result of one single thing happening. It's, again, related to micro-trauma, doing the same thing over and over, and ultimately affecting the same structure and getting that structure to the point where it's not happy. In terms of acute injuries, these are some of the more common ones we see and the ones that I'm going to concentrate on here tonight. First, we're going to talk about growth plate fractures, then ankle sprains, then ACL tears, meniscus tears, and finally shoulder dislocation. Growth plate fractures often occur in your joint because that's generally where the growth plates are. We're always suspicious of a growth plate fracture in a child when the child comes in, had an injury, they have swelling and tenderness in that specific area. As we said before, the growth plate is the weak link. There are ligaments that span the joint, but generally those are stronger in a child than the growth plate is. So oftentimes when we see a kid that comes in that had an injury and has tenderness over a growth plate, even if we get an x-ray and that x-ray looks completely normal, we're oftentimes very suspicious and assume there probably is a bony growth plate injury, and that's a fracture, and that's how we treat it. And that's why sometimes you can go to the ER and the doctor will say, I think the x-ray looks normal, but there's a growth plate, so you should see your orthopedic surgeon. And like I said, we're going to be on the conservative side of the child anytime we're concerned. It's very easy to put a cast on. It can be a little inconvenient, but ultimately that's what's going to allow things to heal. In older children, when the growth plate is closed, we're dealing more likely with a sprain. The most common sprain we see is an ankle sprain. Again, there's no growth plate there, so what gets injured? It's the ligament. The ligament is the structure that connects bone to bone across a joint. Oftentimes, it's an injury where there's twisting or trauma. The tenderness is generally localized over the ligament. The sphere of the injury can range from just stretching the ligament all the way to tearing the ligament. And depending on where it is in the body will dictate what we do. And an ankle sprain, even if there's a complete tear of the ligament, most of the time that's something that's going to deal without any kind of operation or anything like that. Other places in the body, unfortunately, that's not the same. And we'll talk a little bit more about that when we get to the knee. Specifically, the ACL is an oftentimes injured structure we see in the knee. You probably heard a lot about these. It's a very common injury in professional sports. There are many different structures that can be injured in the knee. The ACL is one of the more common. The ACL is one of the stabilizing ligaments in the knee. It connects the front part of the shin bone to the back part of the thigh bone. Basically what it does is it prevents the shin bone from moving too far forward relative to the thigh bone. It can be injured by a direct blow, but oftentimes it's a non-contact injury. Oftentimes people will come in and they'll say they planted their knee, they felt sudden pain, and they heard a pop or they felt a pop. When people say that, we get generally pretty concerned because that's oftentimes the way these people present with an ACL injury. Oftentimes when the injury happens, it causes a lot of pain, and most of the time you're not going to be able to go back in the game and play. So that's another clue that we often ask about to help us make the diagnosis. Through an exam, we can oftentimes tell what's injured, but sometimes we can't. Sometimes the acuity of the pain and severity of the pain prevents us from making a diagnosis. And oftentimes we'll suggest further testing, such as an MRI, which is going to show us the ligaments. An X-ray doesn't show us the ligaments, but oftentimes we get that as a screening test just to make sure that there isn't a fracture. Now, if we find an ACL tear, oftentimes in a young athlete, chances are we're going to recommend surgery because the ACL, unfortunately, is not one of the ligaments that heals on its own. It's an intra-articular ligament, meaning it's inside the joint, and therefore it has a very poor healing potential. We can't even really sew it back together. People tried that for a long time and found that it didn't work. So when we talk about surgery for an ACL tear, you're not going to talk about repair, you're going to talk about a process called reconstruction. Reconstruction basically means we're taking tissue from somewhere else and putting it in place of where that ligament used to be. We can get tissue from the patient from a different location, or we can get tissue from a tissue bank. And the decision to what tissue to use and how to do the surgery is doctor dependent and it's patient dependent. And there's a lot of variability. And the bottom line with it is there's not one right or wrong way to do it. Everybody's different. And like I said, I typically use the patient. Depending, somebody who's a little older, who I think wouldn't necessarily rehab as well, and I'm most likely to take their own tissue as the graft because by doing that, I'm doing more surgery, and that's more to recover from. A younger person who oftentimes is going to have a little easier time rehabbing. Most of the time, I'll use something, some of their native tissue. But again, it's a patient-doctor discussion. Go over all the risks and the benefits and the different options, and we make a decision together. Interestingly, the incidence of ACL injuries among female athletes, for some reason, is significantly high than in their male counterparts, sometimes even 5 to 7 times as high. We don't know exactly why. There are many theories. but it's most likely a combination relating female anatomy, hormones, and brain and muscle interaction. There are prevention programs that are important for both males and females in terms of preventing these. We have that here through our performance center, and ultimately, we can touch on that a little bit later. Meniscus tear is another common acute injury that we see. Again, it's an acute injury, usually associated with an injury. Meniscus, oh, I'm sorry?
Yeah, on this ACL tear, does it usually heal?
No.
No?
If you tear your ACL, it's not.
After surgery, even with surgery, that's
no, you can't generally get it to heal. It's not going to heal on its own, and you generally can't sew it back together. If you tear your ACL and you're an active person and you have instability in your knee because you tore it, then most likely what the doctor's going to recommend is that you get what, like I said before, is called a reconstruction, where we put something else in place of that old ACL.
Yeah, but is it eventually going to?
Well, that new tissue will heal, and it will function just like your old ACL.
So you'll be all right?
Yeah, absolutely. There's a very good track record in terms of ACL surgeries.
How long does it take?
Well, it's probably a good 9 months till most doctors will let you go back to unrestricted activity. So it's a long rehab. It's very successful. Probably 90–95% of people that have it go back to doing exactly what they did before they injured. People have these injuries all the time in professional sports, and even at that high level, they're able to go back and participate.
I know 9 months, but it seems to me that in the case I'm thinking of, she's still not totally healed,
well,
even though it's a year.
Yeah, I mean, again, every surgery
and
after this.
And it is a reconstruction.
Yeah. And unfortunately, the truth of the matter is there's no surgery that anybody does that works 100% of the time.
So what does one do?
Well, again, it depends on what the problem is. I mean, sometimes there's nothing you can do, but oftentimes there are certain complications that can arise, and we deal with those on a case-by-case basis. So I can't unfortunately speculate on one case in particular, but
16 or 17-year-old girl.
Yeah.
Now, does it hurt her to go back to the sport?
Well, it depends. I mean, it depends what the issue is. I mean, if the new ligament didn't heal to the bone and her knee is still loose, then she's at risk for more injury. But again, I can't, like I said, it's hard.
And how does one find that out?
Well, that's something that the doctor would be able to.
You would know?
Yeah.
And he would prevent them from going back?
Well, I mean, he would make a recommendation, but I mean, ultimately, everybody's going to, be allowed to make their own decisions. They'll take, the information they get from the doctor and the recommendation.
Time doesn't help.
Well, again, it depends what the problem is, but sometimes no. All right. Like I said, another common thing we see in the knee is a meniscus tear. Meniscus is cartilage that's in the knee. It's basically a shock absorber between the bones. And oftentimes it's injured when we twist the knee awkwardly and it gets caught between the bones. It can cause the knee to get stuck, it can cause clicking, and ultimately can cause pain. Depending on what your situation is, sometimes people can tolerate meniscus tears and do fine with them, and they don't necessarily have to have anything done about it, but ultimately, most of the time it ends up being symptomatic, and we can make that symptom go away by doing arthroscopic surgery, but again, it depends on each individual situation. Beyond the knee, we commonly see injuries in the shoulder. As you probably know, your shoulder has the largest range of motion of any joint in your body. You can move it all over the place. And we have that for a reason, so we can do all kinds of different things with our arms. But it comes at a cost. The cost is that joint is the most likely joint in your body to dislocate. Dislocations occur when the shoulder receives a strong force that pulls the arm in an extreme direction, such as a fall or a traction type injury. This leads to the ball coming out of the socket. That's what shoulder dislocation is. Just to clarify, that's separate from the shoulder separation, which involves the joint on the top of your shoulder where the bones separate from each other, but that doesn't involve the ball in the socket. When we're talking about dislocation, we're talking about the ball in the socket. Oftentimes, again, this is a traumatic injury. The ball comes out and you can't really move your shoulder, and most of the time, it's going to be so uncomfortable that you're going to seek medical attention right away. Oftentimes, it's going to require a physician or somebody in the emergency department to pop it back in. After you have a shoulder dislocation, assuming you get it put back in a timely fashion, most of the time we recommend a rehab program. People that dislocate their shoulder for the first time do have a chance of redislocating it, but it's not so high that we recommend doing surgery right away. These are some simple exercises that we recommend. Now, if the shoulder dislocates a second time, especially in a young person, then chances are it's going to keep happening. And that's, unfortunately, when we generally talk about surgery for that type of injury. Now that we've talked a little bit about some acute injuries, I'd like to talk about overuse injuries. Again, overuse injuries are from repetitive trauma. They're not usually related to one specific injury. This is a few of the ones that we're going to touch on here today. We're going to talk about little leaguer's elbow and shoulder, golfer's elbow, a condition called Seaver's disease, jumper's knee, and lastly I'll touch a little bit on stress fractures. Little leaguer's elbow is an overuse injury that affects the medial or the inside portion of the elbow. This is the area of the elbow that's most commonly injured in young pitchers as well as older pitchers. It results from chronic stress on the growth plate. Risk factors, obviously, open growth plate, overuse, and poor pitching technique. It basically occurs because the growth plate fails before the ligament tears. When we examine patients that have this problem, they have tenderness on the inside part of their elbow, they generally have loss of motion, they have swelling, and on an x-ray, this is what we'll see. You can see here, this is actually the growth plate, okay? And this growth plate, as you may or may not recall from that earlier knee x-ray that we showed, is usually just a thin line. This one is very wide, and essentially what's happened is the ligament has pulled on this bone and pulled it too far away. And that's essentially what little leaguer's elbow is. Now, how do we treat this? Some general management principles. The mainstay is activity modification. Generally, we try to recommend you don't pitch until your pain is gone. This often occurs after a short period of mobilization or just rest, usually a week or two. You can also try anti-inflammatory medicines, stretching program. Rarely surgery is indicated, and that generally depends on the patient, depends on what their activity is, depends on how long they've been having problems. And what it involves is basically putting a screw or a pin across that growth plate and closing it down and allowing it to heal.
Excuse me, sir.
Yes.
Can this reoccur years later?
Well, in general, when we're talking about little leaguer's elbow, we're talking about stress on the growth plate. So if it happens years later, chances are at that point that person's growth plate is done and it's closed. So it's probably a different process. At that point, it could be a tendinitis or a ligament injury, which again, like we said, that's what's more common in an older person. That doesn't, if you have the little leaguer's elbow as a child, that doesn't make you prone to having that problem as an adult, necessarily. Again, it's just related to activity more than anything. But like I said, if it's recurring down the line as an adult, then it's probably not involving growth plate because the growth plate is probably not there anymore. So it's a similar process, but just a little bit of a different area that's affected. Just a little bit more management. Again, we discourage pitching through the pain. Again, we recommend returning gradually once the pain has gone away, because ultimately, if it's not fixed, it's not addressed, it can lead to a permanent deformity and ultimately a permanent loss of motion, as well as the possibility of arthritis. A similar injury occurs in adults. This is when we talk about tennis elbow or golfer's elbow. This is an injury to the tendinous attachment of the muscle to the bone. It's generally in the same area when we're talking about golfer's elbow on the inside. Tennis elbow is the same process but on the outside. Again, the muscles that attach to that bone on the outside are pulling on that bone and they're getting irritated and they're not happy. It's a result of overuse. People often get it from different causes. It's not always because of tennis or golf, but again, it's some kind of repetition. And it got the name tennis elbow or golfer's elbow because of what tennis players and golfers do. They do the same thing over and over again. But again, like I said, it certainly doesn't have to happen just from playing golf or just from playing tennis. While no treatment is guaranteed to be successful, we often recommend stretching and strengthening to try to prevent these situations. Important things to remember, you want to warm up well before you play. You want to make sure you have appropriate equipment. You want to work on conditioning beforehand, and you also want to make sure that your technique is appropriate. And oftentimes this is where coaches and professionals come into the picture. Moving on to the foot and the ankle, the most common overuse injury we see in the foot and ankle in children is called Seaver's disease. The name's not really that important, it's just basically named after the person who first described it. But it's similar to little leaguer's elbow in that basically what it is a traction injury. It's just a different growth plate in a different place. This is the heel bone, the calcaneus, has a growth plate. The tendon called the Achilles tendon attaches on the back there, and that's the tendon that powers your foot, allows your foot to push down. And anything that repetitively is pulling on that tendon and ultimately pulling on that growth plate can cause pain in that area. And like I said, that's what we refer to as Seaver's disease. We most commonly see it in kids that have growth plates open, generally in young men who are 10 to 13 years of age. And again, the main complaint is pain in the region of the heel bone. In terms of treatment, it's very similar to the elbow issue. We basically try to manage it with activity modification, potentially a short period of immobilization in a cast or a walking boot. In general, this is a self-limiting thing. It will get better, but the bottom line is you just have to give it a chance. You have to let it rest. Shoulders are also prone to overuse injury. We talked about acute dislocations before, but again, overuse injuries can occur in this area as well. Throwing sports, overhead sports such as weightlifting, can cause these problems, so it's important that you use proper technique and a supervised program. Like little leaguer's shoulder, you can have the same problem. I'm sorry, like little leaguer's elbow, you can have the same problem in the shoulder, and we call this little leaguer's shoulder. Again, what it is a chronic stress injury to the growth plate in the shoulder, the growth plate at the top of the arm bone. This is an x-ray here. This is the arm bone. The proper name is the humerus. This is the growth plate here. And ultimately, kids that are involved in overhead activities, most commonly pitching, that area can get injured. That area can get unhappy, and it causes pain. Adults tend to get a tendinitis in the same area. But in children, as we said before, the stress is absorbed by the weakest link. And the weakest link, unfortunately, is the growth plate. In young athletes who don't have an open growth plate, again, as we said before, they often injure tendons or ligaments. We often refer to this injury as swimmer's shoulder, and this is because the most common athlete we see it in is the swimmer. Essentially what you have, instead of an injury to the bone, you have an injury to the ligaments and the tendons that are in the same area. Basically what happens is those tendons get pinched between the bones from repetitive overuse. Symptoms are generally up on the top. Sometimes they radiate down the arm. If it doesn't seem to be that type of issue, there are other reasons people can have shoulder pain, such as labral tears, cartilage tears, dislocations or instability like we talked about before. Rotator cuff tears, they're very, very rare in a young population. That's typically an injury we see in older folks, but not impossible to have that in a young person. Again, the treatment regimen is, you're going to sound like a broken record here, rest. The overuse injury is there because you've overdone it. And the thing that's going to make it get better is rest. And, it's a hard thing for people sometimes to grasp because they're doing something that they like and they don't want to stop. But ultimately, that's oftentimes the most reliable way to get better. Now onto the knee. Commonly referred to overuse injuries in the knee as jumper's knee. This term describes chronic pain in the front of the knee, the anterior part of the knee. Other common names for jumper's knee: patellofemoral syndrome. Another term you may have heard of is Osgood-Schlatt's disease. These all basically are variations of the same issue. Again, we're talking about an overuse injury, so the pain is oftentimes gradual in onset. There's not a specific injury. There's not necessarily swelling, catching, or any buckling or giving way of the knee. It just started hurting and continues to hurt. When the source of the pain is the growth plate, as it oftentimes is in young athletes, we refer to it as Osgood-Schlatt's disease. Again, the name is not important. That's the name of the people, the doctors that first described the injury. The pain, as we said, is a result of inflammation of the growth plate. It's a result of traction again. In the knee, the tendon that connects the kneecap down to the shin bone is called the patella tendon. That tendon, unfortunately, attaches right where the growth plate at the top of the shin bone is. And every time you extend your knee, every time you straighten out your knee, you're using that tendon. That tendon is pulling on that bone. And if it's too much, that bone's not going to get happy. That bone's not going to be happy. You're going to feel pain in that area. Again, the mainstay of treatment is activity modification, rest. It can take a long time to resolve. You know, the nice thing about all these injuries is that, you know, typically they're not the kind of injuries that are going to make you prone to getting something bigger, a bigger injury, something worse. They're overuse injuries, and, you know, with a grain of salt, sometimes you can play with them, but the bottom line is activity modification is what's going to make it go away. If that's what you're looking for, then you're probably going to have to take a little bit of time out.
Excuse me, doctor. I see some people wearing, looks like some kind of straps right below the knee.
Yeah.
Is that what that's?
Absolutely, yes. People wear those around the elbow, around the knee, and basically what they're doing is they're trying to take the pressure off where that tendon attaches to the bone, which is the problem here. By putting that strap on there, you offload that particular location. So yeah, you just you may never have paid attention before, but if you watch an NBA basketball game, you're guaranteed to see somebody that's got one of those straps on. And that's exactly what it's for. So, physical therapy can also help to manage the problem. Therapists do things with stretching and strengthening. They also have other treatment modalities, ultrasound, and stimulators, and different things. If rest doesn't seem to be helping, or sometimes these, you want to get back sooner, sometimes the therapist can help along those lines. But the bottom line is most of the time these overuse injuries are going to heal as long as you give them the appropriate attention. One last thing I'd like to talk about, stress fractures. Our body makes new bone every day. Bone is a live tissue. It gets blood supply and it turns over every day. Usually the turnover process is balanced, but lack of recovery after exercise sessions, inadequate calcium, or rapid increase in activity level can create an imbalance. In other words, you're losing more bone than you're producing. This leads to micro cracks or stress fractures that generally will produce pain in the very specific area where the stress fracture has occurred. The pain generally is always worse with activity, but improves with rest. Female athletes, again, unfortunately, tend to be very vulnerable to stress fractures. Nutritional and hormonal factors are often important. Stress fractures are diagnosed by your doctor basically by history. Somebody comes in, they say, this is where it hurts in this specific area. It hurts when I'm active, it doesn't hurt when I'm not active. X-ray may not show it, so sometimes if that's what the doctor's concerned about, they'll get an advanced test like an MRI or a bone scan. But again, these are very treatable. They don't necessarily always have to be in a cast. The treatment is rest, taking pressure off that bone and allowing that bone to heal. Now that we've talked about some specific injuries, we're going to just talk a little bit about prevention and treatment. Youth sports should always be fun. The win-at-all-costs attitude, unfortunately, can lead to injuries sometimes in children and child athletes. Coaches and parents have the power to prevent many sports and related injuries, as we've talked about, by providing a healthy atmosphere. Confidence, cooperation, and a positive self-image are part of sports, especially children's sports, and should be promoted by adults that are involved. As we said, oftentimes pediatric or child sports injuries are preventable. As adults, we owe it to kids to do our best with the knowledge that we have to try to prevent these injuries from happening. Some things that we can do, always ensure that proper protective equipment is being worn, face masks with helmets, body guards, protectors. It's also important to ensure that any equipment being used meets standards and is environmentally safe. Preconditioning is very important. That's what's going on right now all across the area. Kids are starting to get back into the fall sports, and right now the main focus is conditioning. It's also important that we recognize and treat injuries. And I said it before, as coaches and parents, we should encourage somebody to play through pain. If somebody's complaining, most oftentimes we've got to take that at face value and assume there's something wrong. Additionally, children should always know and abide by the rules of a particular sport. These rules are often designed to keep kids safe from injury. In addition to wearing appropriate protective gear, it's important that we make sure kids know the proper way to use equipment. Warming up before beginning any physical activity, especially strenuous athletic activities, and being well rested gives the kid the best chance to enjoy the sport as well as to play it to the level they're capable. Again, overuse injuries are largely preventable. This is a basic rule that is a general guideline. It's not certainly written in stone. The 10% rule, basically, don't increase your activity intensity by more than 10% a week. Also try to mix your routine. Don't try to do the same thing over and over again. For example, if you're conditioning on your own, do some running, alternate that with things like swimming, and in general that's going to make you less likely to sustain an injury. Stretching before is important as well. Before you stretch, you need to warm up your muscles.
Actually, if I may ask,
sure.
I wasn't quite sure how to approach stretching, whether it be skiing or running, because some people, the latest thing I kind of embraced was skiing a little bit, one, maybe 2 runs, or running maybe a light run for maybe 100 yards, and then stretching, and then going into the full running if you're going to run 5 or 10 miles, or or ski a couple laps, and then after you stretch, then go ahead and ski.
Yeah, I mean, the truth of the matter is I don't think there's one right or wrong way to do it. I think Frank's probably going to touch on that stuff in his talk, so if that's okay, we'll just give him a chance. But yeah, like I said, honestly, there's not really one right or wrong way.
Okay.
Again, you want to try to cover all the muscle groups you can. In general, when you're stretching, you shouldn't feel pain. You want to keep your hands, shoulders, feet relaxed at all times. You don't want to forget to breathe deeply and slowly. You want to avoid bouncing, but focus on slow, steady stretches. You want to be sure to stretch both sides of your body. Despite all these preventative measures, unfortunately injuries still can occur. When you have an injury, the treatment will obviously depend on what the injury is. If you're not sure, rest is the best advice I can give you. You want to also ice it. And if you're not sure, then ultimately that's you might want to consider seeing a physician. The mnemonic we use is RICE. You may have heard of this before. It stands for rest, ice, compression, and elevation. That's generally the place that you want to start. You might want to also consider modifying your activity. And this is probably one of the more important things I'm going to say. The question is, when do you see the doctor? Kids are definitely likely to get bumps, bruises, and other minor injuries. Oftentimes these are not anything that requires a physician, but there are some telltale signs that warn you that it's probably something that you need to see somebody about. Some of these things include the inability to return to play after an injury, the loss of ability to play up to one's potential. Anytime somebody's limping or their motion is affected, and it's generally an easy thing to try to figure out because we've got right and left. And if you have any doubts, compare it to the other side. That's a good test case. Obviously, if there's any type of visible deformity with respect to the extremity, I think that kind of goes without saying that you're probably going to want to seek medical attention. If it truly is a visible deformity, you're probably not even going to want to wait to get an appointment, and that's probably something that needs to be evaluated in an emergency setting. And the level of pain. That's a little bit of a difficult one because everybody's pain threshold is a little different. But try to use a baseline, especially if it's a child, it's your child. What is the normal pattern of behavior? My 6-year-old broke her wrist over the winter, and I knew right away, and it had nothing to do with me being an orthopedic doctor. She fell, and it was just the noise that she made, the scream that she made, it was just different, and the amount of pain that she was in was different. And that's something that you as a parent can pay attention to and know. And obviously, you don't have to be a medical person to figure that out. And if it's something like that, then that's definitely something that you're going to want to consider seeking a medical opinion about. The bottom line is that engaging in sports is fun and healthy. It's good for everybody. Generally, it's a very safe thing if you keep these guidelines and different things we've talked about here in mind. I just wanted to thank everybody for coming out today. Hopefully you got a chance to learn some stuff. Frank's going to talk now a little bit more about preventative stuff, stretching and that kind of thing.
First, I want to kind of build and emphasize what Dr. Malgary said. We have a tendency, I call it the trickle-down effect in sports, right? We have trickle-down economics, we have trickle-down in sports. We see something going on at the professional level, the college level, the high school level, and as youth sports coaches, we look and we say, well, if they're doing it, it's got to be good for us. One of the things that Dr. Malgary said was that, you know, they're not necessarily an adult, they're a little less, but they haven't finished growing yet. And sometimes we look at that and say, well, it's okay, feel the burn, and we take it a little bit too far. What's great about kids is that they're very pliable. They'll adjust. They'll tolerate just about anything we do to them to a fault, and that's the problem. Is they're very pliable. You walk into any weight room, and you'll see kids doing things a variety of different ways to get the job done. And our bodies are amazing machines. Okay, it's got the software package. It's got the ability to heal itself. And it will find a way to get whatever we ask them to do, throw a ball, kick a ball, run, jog, whether they've got the ability or not, this little thing up here will find a way, okay? It will work around the path of least resistance. And what we look at, and I'm kind of leading into the stretching, is that if you think of this principle, and there's a lot of principles out there that we can't change, it's just the way we're built, we have to live with them, and everybody gets the job done, maybe a little bit differently. Otherwise, everybody swinging a baseball bat would look the same, right? But we're all hitting the ball. Some of them look a little bit different, some can throw the ball a little bit different, some can swing a little bit different. But there's no one way, and Dr. Malgary kind of hit on that, there's really no one way to stretch or to warm up. I'm going to give you my point of view and my experience, and hopefully kind of guide you to what I've seen has been successful. But the body will get the job done. There are two things that as our children grow that we need to really be concerned about. You guys know this, if you're here, you have children. When they were born, were they very, very flexible? You can do just about anything with them, right? They bend, but they don't break, which is kind of cool. When we get older, we start to break, okay? The point is as they grow, the bones grow a little bit faster than the muscles, and that leads to that Osgood-Schlatters and the Seaver's disease, in addition to the activities that we put them under, which are the adult sports activities. We say, well, if the adults do this, it's got to be good for you guys, or we want you to be the best. And it's kind of that mentality. Sometimes we need to step back and say, what am I doing here? They are kids, and they'll get by. And when they start breaking down, that's a big problem, okay? Because their bodies can adjust, and we've let it go too far. What happens is, at about age 6, we send them to school, right? Where do they sit in school? In a chair. They sit at 90 degrees. Knees are at 90, hips are at 90 for what, 4 or 6 hours, right? We took them off the floor, we put them in a chair. Now we've got these electronic games, and now we're playing computers and Wii's and things like that. And what's nice about those games is what? If I'm not winning, I hit the reset button, right? I can go back and I can try to win again, versus that real competitive mode. Well, that 90-degree position puts us at some bad angles, but the body's an amazing machine again, and it's kind of the SAID principle, the specific adaptation of imposed demand. The imposed demand would be the sporting activity, okay, or the sitting activity or inactivity. And that's what we need to kind of overcome is, as youth sports coaches, we get those children or those kids after 6, 7 hours of sitting activity. And now we're going to go ask them to do some high-level activities without maybe a proper warm-up or a proper stretch, or what's the right way to do this, or, okay, he's telling me his knee hurts or his calf hurts. Do I tell him to work through it, or is there really something going on here? Go get it checked, come back, and then we'll take it to the next level. So those are some things you need to be thinking about out there as not only as an athlete, okay, but as a coach, to kind of take all those things into consideration. As they grow, Again, the software package working with the hardware, this is something that happens if you take a child development course, you would learn about all of this. But if the muscle becomes tight, it causes, okay, the problem, okay? So tightness will cause a problem or a bad movement pattern, okay? Because the body can't work through that limitation. A weakness in the muscle group allows it to happen because now that muscle can't stabilize or have the strength to get out of that position. As coaches out there, I'm one of you, okay? You get out there and you want that athlete to get into the athletic ready position, right? Whether it's baseball, softball, tennis, what sport are you involved in, lady? Field hockey?
Yeah.
Okay, all right. No matter what the sport is, the athletic ready position is universal, okay? We're here, right? But do we see this sometimes? Okay, we tell them, get down, bend your knees, bend your knees. And as a coach, it's frustrating when they don't listen, okay? Because do we think they're not listening, so we yell louder? And it may not be the fact that they don't hear us, it may be the fact that they're tight or they're weak, and they physically can't do this and hold that position, okay? Just like a squat. We're gonna look at that at the end tonight. One of the most fundamental movement patterns is a squat. You didn't teach your children, okay, to squat to stand up from the lying position, right? We didn't have squat sessions to get stronger, did we? We didn't have core sessions and more crunches in the crib so they could stand up and walk out, right? It just kind of happened, right? One day they roll over, right? First thing happens, actually they lift their head first, right? Okay, so the neck got stronger because it had to, specific adaptation to impose demands. Then what happened next? They kind of roll over. Then they sat up, then they kneeled. Then they started crawling. First time they stood up, they didn't get up and run. Okay, they stood up, they lost their balance, and they fell back down. Okay, that's the software package working with the hardware to say, I need some strength, I need to go hold this position so that this foot can be put in front of the other foot, take a step, now this guy better do the same thing, okay? And eventually, all of a sudden, by 9 months, 1 year, they're walking and running, and now we're like, oh no, okay, now it's a problem. And then we introduce them to sports, okay, we introduce them to school and sports. So posture, those of you young children out there, when your parents are talking to you about posture, they are correct. Your teachers that are talking to you about posture are correct. We need to fix that posture, okay? And then sports and athletics is posture and motion, or it's a dynamic posture, and the ability to get back to home base and be safe and comfortable. Okay, so the thermostat up here is sometimes very difficult to change and get back there. One of the ways that I approach it is I look at posture, we look at movement. The young lady over here asked about movement earlier, flexibility, all right, the ability to stretch and get in different positions, all right, as we get older we can lose that. We need to get back to that a little bit. So let's talk about stretching because that's the warm-up, okay, that's part of it. We do a little bit of balancing, we also do stretching. You had a great question earlier about do I run before I stretch, okay? And I remember as a kid watching Mutual of Omaha's Wild Kingdom. You guys remember that? Okay. You younger children don't remember that. Did you ever see a cheetah pull a hamstring chasing a gazelle? I never saw it. Maybe they cut that part out. Do you think the cheetah, one of the fastest animals, was out there, you know, doing some speed training and things like that? What's the first thing a cat does when it gets up or a dog? It stretches, right? Does it do a dynamic stretch? Right? Isn't that the thing we're all doing right now, dynamic stretching? Okay, does it get up and, okay, all right, here we go. All right, there's that gazelle over in the corner. I'm going to go get it. Now, what's it do? It kind of does a lengthening process, doesn't it? It lengthens, holds, lengthens, holds, okay? All right, you got a dog, you got a cat, watch them, okay? They're not doing anything dynamic, but all of a sudden, boom, they're at full speed, right? And I never saw my dog come up chasing a bird out of the yard with a bad hamstring or anything. It doesn't happen, okay? So why does that happen with us? Just plant that seed out there. Something out there is different, okay? We're too smart for ourselves, I think, sometimes. So what we need to do is kind of look at the stretching, okay? There are many ways to stretch, okay? I'm not going to lock you into one way, but I want you to think about the process. If I have bad posture, sitting, and now I try to take that bad posture and I put it in motion, try to hit a golf ball, try to throw a ball, all right? Now I'm back to what Dr. Malagary talked about was overuse injuries, okay? Repetitive micro trauma, but I'm going to accelerate that process if I don't have good mechanics or the ability to move better, right? Because now I'm creating a different stress on a different joint if I've got a tight hip flexor. Okay, and I'll come back to the hip flexor because I'm seeing, and I don't know if you can share with us, Dr. Malgary, but I'm seeing more young children with more back injuries, okay, recently. And I have a anecdotal belief in that, but we'll talk about that in a couple minutes, all right? But the body will find a path of least resistance. So if I've got a tight hip flexor, and I told that kid to go and let's run a lap, and he's not warmed up yet, okay, or he's not properly stretched, the body will find the best way to do it because I gave him a task. Doesn't care how it gets done, because I didn't tell him the quality was not important, was it? The task that was given up here, the brain heard it, says go run a lap. So I'm going to run the best I can, whether I'm ready for it or not, stability-wise, flexibility-wise, I'll get it done for you, okay, or throw that ball over there. So proper warm-up, we need to refocus on posture, fix the posture, and then that posture will move better because now I've got more flexibility, which gives me more power to use the muscles to throw harder, to swing harder, to run faster. So those are the things that why, or more importantly, why the warm-up is really, really huge, okay? And stretching can prevent a lot of those injuries, okay? The stretching at the beginning. Okay, different types of stretching, okay? Dr. Malgary had up there on the screen. Hold that stretch for 30 seconds, right? A couple times. How many of you guys do that? I didn't think so. Okay, all right. Stretching is not fun, all right? I'll admit that. I've been doing this for way too long, 20 years, okay? Get somebody in, you stretch, no. What do? They want to get right to the lifting, right? Or I want to get right to the sport. And that's wasting time. I want to get right to the skill. So, how many people stretch 10 seconds? Hold the stretch for 10 seconds, even 1 or 2 times. Okay, all right. There are some studies out there, some of them. You can find always a study to support what you're thinking anyway. I'll cite one of our physical therapists cites a study where they took rabbit tissue and they put it under stress. They did it 1 to 10 times, and they held it under tension for varying times. And what they found was that 4 times for 15 seconds, you got your best length in that muscle fiber back, okay? So that seemed to be efficient. Any more repetitions to that, any longer, didn't seem to make a big difference. Bell curve, the adults know what the bell curve is, right? As I approach max, I start to slow things down. I reach my limits. And that's kind of what that study showed as far as stretching. Then a couple of years ago, we came out with this other study on static stretching versus dynamic stretching. And all the pros are doing it. So the high school slowly adopted it, and now the youth sports are doing the dynamic stretching. And I'm going to put you on a spectrum here, okay, of flexibility or your ability to move your body, okay? Over here, if you have limitations, okay, the dynamic stretching is only going to make you accelerate an injury quicker, okay? Because just like running, okay, I'm going to bypass, the brain is going to bypass that resistance in the stretch and figure out a way to do it the best way that it can. So if I've got a limitation, I have to start over here with a static stretch or a myofascial release, the foam rollers. We have to do something like that. In order to be dynamic over here, it takes time, okay? It didn't happen overnight. You get tight overnight. It was a slow progress. The body didn't recognize it. The adaptation to the imposed demand, kind of a use it or lose it philosophy. Body said I don't need it, okay. And it developed its own muscle memory or muscle path to get there based on the task that we gave it. So here we are at static stretching, or myofascial, some foam roller. Now let's move over here to some active stretching. That's where I kind of like to start and evaluate what an athlete or an individual can or can't do. All right, so we're looking at posture here. So an active stretching would be where you take the muscle, you pre-stretch it, maybe forward, and then we're going to teach that muscle how to rotate or move laterally in a pre-stretched position. Okay, body moves in 3 planes. Okay, body moves this way, body moves this way, and the body rotates. Okay, those 3 planes, or a combination of all of those 3. Injuries occur with mostly rotational forces. Okay, most people don't stretch that way, do they? Most of us stretch doing something along those lines or in this plane, but very rarely do we add rotation. So an active stretch pre-stretches you in one of those directions and then adds the other direction into it. Okay, so you're really prepping that ankle, the knee, the hip, to move better around the joint and give that muscle more elasticity for more snap and power. Okay? Then ultimately I'm going to get over here to the dynamic. Okay, kind of what you were saying. If I'm going to go for a run, dynamic is the goal. If we find someone that's got real good mobility, good flexibility, we can skip all of that stuff and we can start right over here with dynamic. That's great. But we usually don't find that often. That's a rarity anymore. And what that study with the dynamic came out and said that the static and the active decreases performance. Okay? Then why haven't injuries reduced because everybody's doing dynamic now? Right? Doesn't that make sense? If this all decreases performance, it probably also is creating a possibility of increased injury. Now I'm doing over here, I'm doing all this dynamic stretching. I'm not seeing a reduction in injury, I'm actually seeing an increase in low back injuries. Okay, yes?
What's a dynamic stretch?
Dynamic stretch is taking the muscle at a higher velocity, almost like a ballistic stretch, kind of what Dr. Mellier had a slide. We don't want to do that. The reason is because you haven't prepped that muscle. It's like taking a rubber band and going bam, 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 and you're slapping it up against the end range. Pretty soon what's going to happen? It's going to break. It's going to wear down. Okay? So I haven't prepped it to tolerate that. Now sports, we don't do that at a high velocity over reps, like high reps like that. But eventually that's what sports is. It's high velocity, right? Very low resistance, wham. It's going fast and quick and powerful most of the time, right? Soccer kick, boom, explode. Okay? So I need to teach that muscle how to handle my body weight, stop, decelerate, and then rotate around my ankle, my knee, my hip, all right, to impart all that force on my foot on the soccer ball, or through the back on the ball. Okay? So we take a look at the screens. We'll do that in a second. But so we start with an active stretch. We always start from the bottom up. First thing that happens when you get out of bed in the morning, your foot hits the ground. All right? There's a bunch of reflexes that come up through your system and say, okay, I'm ready for this. Okay? Your foot has to react, your knee has to react, your hip, your core has to react to that in order to accept your weight. Okay? Decelerate so you don't fall down. Okay? Be able to stabilize, let this leg come up. So we want to reinforce that whole motor pattern. So we'll start from the calf, we go to the hamstring, then I want to work my way around the hip. I want to hit my groin, I want to hit my hip flexor, most important, okay? I want to hit the piriformis group on the outside. We want to get the lats, particularly if I've got an overhead athlete, a swimmer, tennis. I want to get the pecs in order so I get some extension up here, reaching, throwing, okay? If all of those muscle groups are pre-stretched and prepped, my risk for injury goes down tremendously, okay? And some of the programs that we've worked with, we've seen some incredible results by working that and then getting to the dynamic next, picking up the pace. So we do an active stretch first, and then we do the dynamic afterwards, because that's more sports like what Dr. Malgary was alluding to. I want to do something that's very sport specific. So we work that in. Okay. Any questions before I do a quick screening here? Okay. Did I answer your question about the warm-up?
I really don't take one foot. I just like to hear, but it seems like there's, like everyone's saying, there's no real one universal answer. It's somewhere between, and it's person-specific as what you want to try to accomplish.
Yeah. Here's a great example. If I get a young dancer in here, what have they worked on? Forever. What do dancers need to do?
Stretch.
Stretch. And what are they stretching?
Legs.
Hamstrings, groin. You know what's tight on dancers, gymnasts? Pretty much across the board. So that hip flexor, didn't I? Because they're working on doing splits, right? And being real flexible. So we'll come in and their leg goes right up to their head. Okay? We lay them on the table, we test their hip flexor, it's tight as a drum. Okay? How do they all look when they're standing? Right? Okay, I'm exaggerating, that's the tight hip flexor. Okay? That's your dynamic warm-up. That hip flexor, because as I sit, okay, your hip flexor lives in the front of your spine. This is awesome. You see that? The hip flexor lives right here, connects to the front of your back. Okay? It comes down through your guts, all right, and attaches to the front of your thigh right here. Okay? And we call it the hip flexor. Okay? Check this out. It comes down and it attaches to my thigh. Does it go from inside out? It does, doesn't it? So it not only goes from front to back, it goes from inside out. Okay? So could I say that that is a hip flexor stretch? So I've prepped my hip flexor in this plane of motion when I do my groin stretch, or I'm actually getting my hip flexor, or I'm getting those long adductors that come down and attach to the inside of my knee. Okay? Let's take a sport. I don't know what you guys are coaching. So kid comes in, he plants, play goes the other way, boom. Okay? There's rotation, right? So wouldn't it be a good idea to stretch that hip flexor in this plane with my hips tucked and then teach it how to rotate there? Now I've taught this whole muscle group in this whole region here how to load, explode, get out of there and take off in the other direction, so I don't have a groin pull or I don't have a hip flexor injury, or more importantly, in the younger kids, a low back. Because as that muscle loads up, if it has a limitation, if it's extremely tight, because I was sitting all day long and now it's shortened, okay? And I go to stand up, okay, and I lower that muscle that runs from here to here. Is it going to pull that bone out of place, or is it going to pull these guys out of place? There's the compensation right there. As I go to stand up, this happens. Because this muscle's so tight, it overrides these little guys in here. That's your core stabilization, okay? So now I'm walking around school like this. I got to go to practice. The first thing I do is I do what? I do my dynamic. One of the dynamic exercises is a butt kicker, okay? And so we're doing this, okay? And their backs are going just like a twig. Okay? It's not today, it's not tomorrow, it might be next year, okay? Then all of a sudden now I've got a disc problem, I've got back pain, Mom. That's okay, take 2 Advil, go to practice, right? And then it builds and builds and builds. I go to the doctor, and I have to go to a therapist, and all of that because this guy's tight, okay? Compensation pattern, over time, kids adjust, they can take a lot, and then there I go. So that's a huge contributor. And that's what I think we're seeing, is because coaches have said, this is the stretch for the thigh, right? We all do this. How many kids can get their heel to their butt? Just about all of them, right? Okay, so you just hit 3 out of 4 quads. Okay, you miss the main guy that crosses 2 joints. He's the problem, what we call the rectus. He attaches up here, comes down, crosses the knee joint. He's the tight guy because he also is involved in resisting hip extension. Okay, the hip flexor is tight, so now my back takes the hit. Okay, I believe that's what's going on. When this guy gets tight, and there's a thing called reciprocal inhibition, again, it's something that we can change, that's a grounding principle. When one side's tight, the back side gets weak because he can't fully contract. That fully contraction is my glutes. My glutes are my powerhouse. When I swing, when I throw, when I run, it's a big, powerful muscle back here, okay, that contributes to my low back, okay. All right with that? Not too much, sorry.
Well, one of the fitness trainers I had really preached the value of hanging. He has actually a strap and he hangs. He recommended that I do that 10 minutes a day or something just to stretch, I guess, my back a little wider. I'm seeing the value of that now.
Sure, and you're getting traction through here, but you're not specific. Here's the specific adaptation to the post-demand. If I take that hip flexor and I don't put any stress on it, it's going to take even longer because you're hanging there, right? Okay, so it's getting a little stressed, but not enough. If I take that hip flexor, all right, I'm going to give you the hip flexor stretch that I teach our kids, all right? I'm here. They can't cheat, though, because the kids want to cheat. So if you're going to do it, we got to do it right. And I'm very big on quality, okay? We got to go here, no lumbar extension. They can't do this, okay? Pelvic tilt, core's turned on, glutes driving forward, big hip flexor stretch right now, okay? So now that hip flexor is saying, look, isn't this how I run? 1 foot's forward, 1 foot's back, boom, right there. Triple flexion, triple extension, okay? So we do this beforehand, and we get up on our feet, and we teach our speed training and things like that in triple extension, triple flexion. So I've taught this hip flexor how to extend. If he's extended, my glute can now power forward, but I've also taught that hip flexor, he's on stretch. He can help my glute swing the leg forward that much faster, can't he? Because now he's loaded. I've taken that rubber band, made it longer, and now I can snap and fire this leg forward when I'm running. So we go here. Now if I got a baseball player, softball player, overhead athlete, okay, here, let's tie that stretch into my upper body so I'm getting the core involved. Let's go here, okay? Let's do some lateral plane. So I've pre-stretched my hip flexor here. Some of you guys can try this at home, okay? And then let's make it even more baseball specific. Let's tight here. We tell the kids, point at my target, reach back and throw, right? Okay? When you do that, what you're adding into the whole complex is you're teaching this to stretch through your core, through your abs, through my pecs, through my lats. And if they can't get their arm fully extended, it's probably because they're tight in their pecs and they're tight in their lats. Okay? And that's why they're coming down 3/4 or sideline, because they can't get over the top. What do we tell them? Throw over the top, throw over the top, throw over the top. They can't. Okay, so if we're observant and can pick that up, we can help them. And that's where, you know, coaching specifics will come in. I work with golf pros, and they talk about they'll alter the swing. Okay, they alter the swing because the golfer has a limitation in their swing. They're tight somewhere, and they can't get through it, so I can cheat. If I open up my hips here, as a golf pro, if I turn this or do that, I'm cheating the body in order to get a better swing. Does that make sense? So that's what a lot of, if we fix the body, now everything becomes a lot easier. The body can do whatever I want. Now I can turn my feet to get a hook or a slice or something like that. I'm not stuck with that one. I'm not locked up. Okay, now my hips will turn. If you're teaching baseball, right, that's all where all our power comes from, the hip turn. Okay, I'm not keeping my hips locked. That's bad for the back. My hips are staying there. That's a bad back waiting to happen. Okay, I need those hips to turn. My shoulders and hips turn at the same speed, and only at the very end did they disconnect a little bit. Okay, and I had enough time and enough flexibility to absorb all that power that I generated by loading and exploding. Good stuff. All right. Okay, I know I'm throwing a lot of different things out there. So I just gave you a quick stretch there. Hip flexors actually incorporated the core, the chest, the lats. Let's do a couple quick tests here so you guys can see what you're looking at. Young lady, would you mind coming up front? Is that okay?
Yes.
What's your name?
Willow.
Willow? Thanks for coming up. What sports do you play?
Softball, gymnastics, swimming, diving, field diving, cross country, basketball, and tennis.
And how'd you get here tonight? You're skipping one of those, right? No? Okay. All right. So, we talked about gymnasts. The answer, she gave me a lot of things there. Okay. So, first thing we're going to do is I'm going to have you face the audience there a little bit. Okay. Very good. I'm just kind of generally checking her out a little bit. Okay. Once you turn sideways, okay, I'm looking at posture. Okay. I just want to. What do I see? She lined up good from the front. She lined up good to the side. So if you let your hands hang to the side, please. Okay. What I'm seeing, I'm trained to look at that. Okay. She's got some forward posture here. Okay. So already I know that she's probably tight in her chest. All right. Her pecs. I don't know about her lat yet. Okay. She may not be. It just might be an overactive pec. All right. Trying to protect something else. Okay. So we're going to try to take a quick peek at that. Are you a pretty good softball player? Play travel ball? On the weekends and tournament teams? Yeah? What position?
Center.
Center? You gotta be quick to play out there, right? Okay. Alright. I'm gonna ask you to do this for me. We're gonna take a look. You're gonna put your arms over your head like this for me. Okay? You're gonna watch me first, okay? Then your feet are gonna be about shoulder width apart. Okay? And I want you to put them parallel like you're standing on the railroad track. Tracks, there's two of them. Okay? Then you're gonna sit as deep as you can. And stand back up. Just like that. Okay? Face everybody.
Again.
Again, I would like you to put your feet parallel like you're standing on a railroad track. Okay? Go ahead. Not too bad. I would like you to face this way, and I would like your mom to see what you're doing from the side. Okay? Turn a little bit more for me, please, Will. Very good. Fix your feet. All right, good. Squat. Okay. One more time for me, please. Not bad. So, a couple things going on there, all right? Not major. She actually did very well, all things considered, all right? I would work on your core a little bit, tighten that up. Flexibility-wise, you look pretty good. You do pronate a little bit at the bottom, okay? Which means your knees are coming in like that. Not a showstopper, okay? You just need to work on those hips, work on some balance things to strengthen those foot muscles and see if we can stop that a little bit, because you do need pronation. You guys have heard of the anti-pronation shoes out there. Pronation is load, supination is the explode. Okay, so we need a little bit of that. Too much of it's a problem, not enough of it's a problem. So we need some kind of gray area in there to help us in our walking and our daily activities. All right, let's check your balance. Okay, what I would like you to do is just lift one leg up like this, reach out, touch your heel down, and come back up. Just see how you go. Okay, pretty good. You stay tall, Warren. Not bad. Let's see what the other leg does. Back up and over, just like you're stepping over. Okay, pretty good. You said gymnastics, right? Okay, all right. She's got a great combination. She's cross-training. She's cross-training a lot, okay? And it's probably protected her a little bit, okay? Being that she's done so many sports. Gymnastics is good because it works on all those things, body weight, core, some of those things. Sometimes to a fault, though. Very nice job. I want to check one other thing with you, okay? What we're going to do is an inline lunge. I want to see what your strength looks like, your balance and your flexibility all at once, okay? It's probably pretty good being a gymnast because I'm going to put you on the balance beam here. You need to stay nice and tall. And I want to see you drop down on a knee and stand back up. Okay. I need this to touch your head, your shoulders, and your hips. And that looks good. I would like you to put this hand behind your back. Reach that way. Hold that right there. Very nice. Now, one thing we'll hold on a second. Come back up. Put this foot right here and go forward just a little bit. Hold it for balance. Turn that foot in just a hair. No, other direction. Very good. Stay right there, nice and tall. And on your ready, go ahead and feel confident. Stand back up. Very nicely done. Okay. All right. Didn't see a whole lot of issues there, right? She got into a pretty good athletic ready position, no problem, did she? She actually got to where I needed her to get, all the way down into a deep squat. She's got good mobility in her hips. Just a couple little issues to work on, but she would be good to go almost from the get-go. We're just going to work on her shoulders a little bit. I'd like you to turn around, please. And what I want you to do is you're going to tuck your thumbs inside your fists like this, okay? You take your hands, one hand goes over the top, one hand goes in the bottom. Okay? We measure the distance here between those two, okay? Now, go the other direction. Can you guys see the difference? Okay? Come back out of it. All right, that's an issue. And just what's going on there, just to give you a quick, if the front's tight, what did I say about one muscle being tight? What happens? The backside's weak, okay? So she probably is lacking a lot of shoulder stability. She's got a lot of mobility to compensate for that lack of stability. Some other muscles trying to pick up the slack for it. So her shoulders are rounded right now. We need to get these scapula living back here, okay? So we would do a lot of scapula stabilization exercises with her mom, okay? A plank, but a plank done properly, okay? Maybe some rotator cuff exercises, some rhomboids to bring this back. Turn to the side, just turn the whole body. Okay, pull those guys back. Now, that look better? Okay, now I'm gonna ask you, does that feel weird? Not too bad, just kind of hard to do.
Yeah,
Hard to stay there, right? Okay, so that's negative feedback right now. Okay, here's the software program telling the hardware, I don't like that. Don't do that anymore. Okay, so go back and relax. Okay, that's the efficiency of this guy to a fault. Okay, down the road, she's doing fine right now, right? No shoulder problems, okay? It's gonna come at some point, all right? Unless she's one of the lucky ones. Okay, thank you very much. Does anybody have any questions?
I have a question. We talked about Little League elbow before. Okay. What kind of stretches would you do for that, for tendonitis or whatever in the elbow?
For the elbow?
Yeah.
First thing I would do is I would attack the shoulder, okay? Most of the time, majority of the time, it's something like what Willow's got going on there. It's the shoulder complex becomes tight back here, okay? This little corner, that's your rotator cuff, posterior cuff. The pecs become tight because, right, I'm trying to throw really hard. So now this gets locked up. Compensation, elbow. You got to decelerate 60 miles an hour, okay? So I always go after the pec, the lat, work on the rotator cuff, which we call the sleeper stretch. Stretch this out really well, and then we'll go after this because here's the signal. Pain is the messenger. Might not always be the problem. That's usually 90% of the time, all right, in a case like that. So for the elbow, we're going to go down and in. That's a hard stretch to teach even adults. And then the easier one is here to get both sides of the elbow, the lateral aspect and the medial aspect, okay? You can certainly have the kids put their hands on the bench in the dugout here, okay? And put their hand up, rest it here, tell them to push this out so the inside of the elbow points to the sky, that part of the elbow points down, okay? And you're looking for a stretch right in that big muscle group right there. This one's the easy one, okay, to get a stretch there. If that's too intense for them, have them come hands on a clock, 3 and 9, and then slowly work them back to about 6 o'clock. But again, I want to see good posture when they're doing that, okay? I don't want to see them all like this, you know, have them engage. You can do it up against the wall here, okay? Something like that. There's a ton of ways to get the job done, but it's got to be quality. You're looking at, just look at posture, okay? And the rotator cuff stretch is a tough one to teach also when they're the sleeper stretch. Is that what you teach Little League? Or coach Little League?
No, I'm thinking of myself and my granddaughter.
Okay. Yeah. We certainly come out, we come out to the teams and teach them our methodology to help prevent injuries for the warm-up. And it's not just the stretch. We go from the stretch into the core exercises. The core exercises educate the muscle that's weak to say, hey, I just stretched you, hip flexor. Here's how these guys actually can push a little bit more now and become stronger. That reinforces the stretch. It accelerates the whole process. Then we go a little bit faster. We do the high knees, the butt kickers, the slides, the karaoke, then the sport-specific stuff, and then whatever your activity is. Yes?
A couple actually, but I'm going to try to start with where we were working here. I'm a personal trainer and I work with a variety of people. One of the groups I do work with was a high school girls volleyball team. And I found a lot along the lines of what you were saying, posterior pelvic tilt. I'm wondering what you personally would address that I've been trying to do other than the obvious hip flexor stretching and extension is also abdominal strengthening. But do you recommend any low back work as well, since that's really your opposing muscle groups, or do you focus more on stretching the flexor or strengthening the weaker opposed muscles? If you
I know where you're going with it. Yep. Okay. So this is tight. This is weak.
Right.
Okay. Stretch the hip flexor. Do bridges. Okay. Don't care how you do them. Make sure they're not getting hamstring or lumbar irritation, fatigue, because these two are the backup plan. Hamstrings and your lumbar erectors are the backup plan if the glutes don't work. The glutes are your primary hip extensor, not your hamstrings and not your low back. Okay. Deadlifts. Okay. There's no such thing as a bad exercise unless it's done wrong. Okay, so coaching is huge when you're training somebody.
They do a soft, stiff leg deadlift with them a lot.
Modified.
Right.
Yeah,
Real
that's good.
locked on, but just a soft knee.
Sure.
Not a full knee flexion deadlift.
And you want to make sure that they're getting it in the glutes and not the hamstrings when they're doing that.
Right.
Don't mistake hamstring hyperactivity for a hamstring stretch. Okay? Because what's going to happen is if the glutes are weak and you put them in a bad position, the hamstring's at a disadvantage here, correct?
Right.
Okay? So I got to ask my glutes to power more to get into that upright position. So if they're feeling that, you need to do more modified, more bent knee to kick in the glutes to reinforce the hip flexor stretch. And they got to finish tall. If they finish here,
Right.
I'm reinforcing tight hip flexors. I haven't told my glute, boom, finish tall, good posture, lock. Here, I'm done.
That's another area that I found where we were going talking about tight pectoral muscles and found a lot of weak rhomboids.
Correct.
Seems to be very prevalent in a lot of the cases that I work with.
It's gastrocs, hip flexors, pecs. You hit those three muscles groups and strengthen the antagonist to that's half your battle. And I'm not just talking, and young girls, no offense, they're the worst, okay? Because the trickle-down effect, as coaches, a lot of us have taken those higher level exercises and skill activities and said, you need to do that. They're not ready to do that, okay? They don't develop, the hormones haven't kicked in on them, okay? All right, unless they started at a young age, like she did in gymnastics probably, right? Started very young. So as she grew, it's like Ferdinand the Bull, not Ferdinand the Bull, who was the guy that carried the bull on his shoulders?
Pick them up every day.
Right, pick them up every day. There's your specific adaptation to impose demands. She's been doing that since she's 5, so she can handle her body weight fantastic. You don't see that every day because that's a special population, okay? But you don't see that, so that's kind of the area where you need to go with that. Yeah. Anything to strengthen the glutes, to reinforce the hip. I do the hip flexor stretch first.
Right.
Or you're banging up against the end, and they're not going to be able to fully extend. Okay, now you're going to get erector, overuse, and hamstrings are going to kick in and try to help, and that's not their job. It's not their primary job. Okay, good stuff.
Well, one more.
Oh,
No one else
okay,
has a
Doc,
question.
you want to come up in case anybody has questions?
Just a general order. Sorry. When we had talked earlier about stretching, and starting basically with a static stretch. Now, again, with say teenagers especially, would you recommend some type of activity prior to that stretch? I mean, I usually have them do something just to get moving, just to try to bring temperature up, things like that. I really don't like stretching them cold. They are very flexible to begin with. So a lot of the stretches that I have them do, they tend to carry to an extreme point, even cold. And I mean, if it was me, I'd be in pieces on the floor watching them do some of the things they do. But I'll usually have them do a few minutes of something. But again, the thing I have in the back of my mind is, okay, we really haven't stretched at all, and I may have them just throw a ball back around the floor, volleyball back and forth each other, or bounce them up and down the wall or something like that to keep moving. So would you recommend static stretching prior to any activity, or?
Yep, I'll go back to my cheetah example, okay? I know where you are. I changed my whole outlook on things about 12 years ago, okay? Here was my speech 12 years ago. Silly putty, put it in the oven, warms it up, pull it out, it's nice and pliable. I'm not silly putty, okay? I'm a human being, I have neurological input that says don't do that, okay? That's gonna hurt and things like that. When I've had D1 ball players in here go through our warm-up program, the stretching, I didn't show you all of it, a couple of things. There's sweating bullets going through the warm-up without running.
Right.
You're increasing body temperature when you do the active stretch because you're using the core to drive different areas. I'll give you a quick, the calf stretch, okay? Here, heels on the ground. I'm actually doing a quad set. I'm tightening up my quad to drive my heel into the ground. What am I doing with my arms? Support my body weight, right? So they don't get to take a break, okay? Now I'm going to drive my hips laterally, okay? To stretch the medial and lateral gastroc head, but I'm also getting my perineals, I'm getting my posterior tib, and I'm also taking my shoulders and doing what? I'm doing almost like an incline bench press, aren't I? Low level, I'm not hurting myself. I'm waking up those scapular stabilizers for the young lady in the back, okay? I'm turning my core on, I'm waking up for what I'm about to do, okay? So that's gonna raise your body temperature.
Well, agree,
Right.
but no
So
argument there.
here's my thing. You send them for 2 laps, okay, to warm up. They're not cross-country runners, right?
Right.
Okay, but the football coaches do that, and then we sit over here in the corner and we talk about what we're gonna do for practice today. Okay, rather than focus on the quality of what's going on in the field with the kids. All right? And I would rather see that. I'd rather see you do that and ensure the kids are doing it right to have better results at the end. Okay? Because you're gonna prevent the injury. You're gonna improve the performance. All right? Hopefully they don't end up in the box office. But you know, there's all the traumatic injuries that we talked about that we can't really. So could some of this stuff decrease the severity? Possibly. It could. But the overuse is really what that stretching is going to target, okay? And the balance and the core stuff. So I'm a believer that you don't have to do that. If a kid comes to me and says, Frank, I feel like I need to ride a bike or do something, go ahead. Okay, go ahead. I'm a personal trainer too. Do that on your own time. You can ride the bike anytime you want. Okay? But when you're paying me to watch you ride a bike, that's not me, okay? I want to help you.
That's what we did years ago.
Sure.
It's actually comforting to me because that's what I'm more comfortable doing. But a lot of people will start telling you, you gotta do this first, you gotta do that first. And we always stretch first. That's what we did before we did anything.
Yeah, but in a progressive manner, in a
Right,
logical,
right. You're
progressive
right.
manner.
Correct.
Yes.
Okay, I'd like to close it up now. I'd like to thank everybody for coming. It was a very educational seminar. I'd like to round of applause for the presenters.